Hello, this is Peter Chang. I'm happy to present the ASRA webcast presentation on calcific rotator cuff tendinopathy. We will be discussing its treatment using fenestration and lavage. I will present a case presentation. Its pathology and treatment will be then discussed. Patient's instructions will be provided. A simulated video demonstration of the procedure will be included. And finally, I will discuss billing and coding information. A 46-year-old female presents with chronic right shoulder pain exacerbated with elevation of her right arm that radiates to her neck. She has tenderness and pain over the humeral head and a normal neurological examination. What is your differential diagnosis? The differential diagnosis includes shoulder impingement, adhesive capsulitis, oftentimes called frozen shoulder, rotator cuff tendinopathy, shoulder osteoarthritis, and calcific rotator cuff tendinopathy. For the purpose of this presentation, we will specifically address calcific rotator cuff tendinopathy. Crystal hydroxyapatite deposits are typically found within the supraspinatus and infraspinatus tendon. Females, especially in the ages of 40 and 50s, have this condition. This pain and range of motion limitation normally resolves within a few months. However, it can occur for years. Imaging of the calcium can be easily seen on either ultrasound or the radiograph. In the radiographic examination, on the left side, you will note this white asterisk indicating the calcium deposit. It is embedded within the supraspinatus tendon. The calcification, generally speaking, is hyperechoic relative to the muscle. It has a nodular and many times a granular appearance. And when the nodules are extremely hard, you'll typically see posterior acoustical calcification. On the radiograph to the right, you'll also notice a small white asterisk showing a radiodense structure locating the position of the calcium. Calcific rotator cuff tendinopathy consists of 3 stages. In stage 1, the pre-calcific stage, there is fibrocartilaginous metaplasia of the matrix. Patients at this time are asymptomatic. As the condition progresses to stage 2, that is the calcific stage, 2 phases characterizes this time period. The first is the formative phase, where calcium is deposited within the matrix. In the second phase, this reabsorptive phase, there is cell-mediated reabsorption of the calcium. This is the phase wherein patients are symptomatic. Finally, as the calcium gets reabsorbed, the tendon reconstitutes within the matrix, and the patients now are pain-free. Is there a role for platelet-rich plasma in the treatment of calcific tendinitis of the shoulder? A case report of a 44-year-old woman who was treated with a series of 6 PRP injections 3 times per week for a period of 2 weeks into the subacute bursum did have improvement. However, whether this occurred as a result of the injection or the normal resolution of the calcium remains undetermined. What are the contraindications to fenestration? Because of the fear that a partially torn tendon could be completely torn after fenestration, some investigators recommending avoiding fenestrations when there is over 50% tear of the tendon. As with any interventions, issues regarding anticoagulants, bleeding disorders, and infection at the site of the procedure would warrant postponement of the fenestration. Equipment and medication needed would include a ultrasound machine with a high frequency linear rate transducer, typically 10 to 12 megahertz, sterile transducer cover, ultrasound confidentiality will be needed. For the aspiration of the calcium, you will need a large bore tuning needle. You also need to have syringes, hypodermic needle, sterile gloves, of course. Medication, I typically use lidocaine 1% for local infiltration, and you will need also corticosteroids to inject into the subacromial bursa, and sterile saline for barbotage. The position of the shoulder for fenestration is illustrated on the photograph on the left hand side of the slide. Here you will see the ultrasound transducer in plane with the supraspinatus tendon, and the needle is directed in plane to the tendon. On the right hand side of the screen, you'll notice the calcium deposits that were aspirated after barbotage and lavage. This slide illustrates the shoulder position and how the needle and the transducers are oriented for the procedure. In the slide A, please note the needle and transducer position. In slide B, please note how the needle is introduced into the skin and into the adjacent muscle to inject local anesthetic. And please note that in slide C, the needle, as it is directed above the calcium, which is labeled C, local anesthetic typically is injected at this location. This sono video demonstrates the needle entering to infiltrate the subcutaneous tissue above the calcium deposit. Please note the acoustical shadow underneath the calcium. This illustration demonstrates the technique of fenestration and lavage. On the left hand side of the screen, you'll see fenestration. Please note how the needle breaks up the calcium. There's a kind of like a stabbing motion, very similar to chipping ice. On the right hand side, you'll see, using the two needle technique, how saline is injected from the superficial tuning needle, and the subsequent calcium and saline is aspirated from the deeper tuning needle. So it's very much like flushing out the calcium deposits. This sono video demonstrates how the needle is introduced to fenestrate the calcium. Notice how the needle goes back and forth to chip these small pieces of calcium. This sono video demonstrates the two needle technique, which is used to fenestrate and to barbotage the calcium. Please note that the upper needle is used to irrigate, whereas the lower two needle is used for aspiration. This video demonstrates the actual lavage technique, where fluid is injected into the calcium. At the end of fenestration and lavage, the subacromial bursa is injected with corticosteroids. From the trauma induced from fenestration, the patient will experience a very painful inflammatory response, and the steroid minimizes this response. I have found that most of my patients seldom have severe pain after the procedure, and I attribute this largely to the corticosteroid injection. This video demonstration shows the needle advancing between the supraspinatus tendon and the overlying deltoid muscle. Please note that as the needle goes into this area where the bursa is located, the injectate will distend the bursa, and you frequently will see the steroid injected and distending the bursa. Although I inject corticosteroids into the subacromial bursa after fenestration, I do advise the patient to avoid non-steroid anti-inflammatories for about 2 weeks. We're trying to promote inflammation as a first step to healing. We also advise the patient not to apply ice for the same reason. Because of the potential for a tear, we advise the patients to avoid heavy lifting or exercising it. In summary, fenestration and barbotage has been shown to be safe, simple, and very cost effective. Additional treatments may be needed in the future. Some of the caveats that should be emphasized is the differential diagnosis must exclude rotator cuff tears, impingement, and shoulder capsulitis. To promote the range of motion and the patient's strength, I advise the patient to see the physical therapist to undergo increased range of motion. Please see a video of a simulated fenestration. Hello, welcome to the ASRA webcast presentation on fenestration for calcific rotator cuff tendinopathy and also for lateral epicondylis. Today we are very fortunate to have our model, Linda. Linda, would you like to say hello to our audience? Okay, great. So Linda has requested that I do not poke her, inject her, or do any invasive procedure, and I certainly do not want to hurt her. So today we're only going to simulate the procedures. And for the purpose of this demonstration, we will not use sterile technique. Obviously, in your own practice, you use sterile technique, but for our purposes, it'd be much easier if we just demonstrate the technique. Now, the first thing I'd like to do is show you how we position our patient. So I have Linda in the semi-reclined position, and I have her coming off to the edge a little bit. And then notice how the arm is slightly put along toward the rail. And I will be scanning her with a linear array transducer. Usually we use about 10 to 12 megahertz, again depending on the size of your patient. Linda fortunately is very thin, so we're going to have a higher frequency transducer. And over here we have our ultrasound machine. So what I like to do is, first of all, show you how we scan to find the supraspinatus tendon, which is the most common tendon involved. Here I'm scanning Linda's tendon, and I'm looking at the ultrasound machine. So would you please show our audience the picture of the supraspinatus tendon here? So you can here see the supraspinatus tendon, and I'm positioning it better for you here. And I'm just going to freeze the picture. And using our pointer, we have here the supraspinatus tendon. This is the overlying deltoid muscle, and obviously this is the cortex of the humerus. Please note how the edges of the tendon goes to the greater tuberosity. Please also note that we have a very thin line, semicircle, which is located between the tendon and also the muscle. This area is where you will find the bursa, and we will be injecting this bursa at the end of the procedure. So this is a nice picture of the longitudinal view of the supraspinatus tendon. I have here a hypodermic needle which is blunted, and we will then demonstrate how we will then anesthetize the skin. So we see the image, and then we simply have the needle placed parallel to the beam, and we will then anesthetize the skin. After the skin is anesthetized, we will take a Tui needle. I usually use a 14 gauge or 16 gauge Tui needle, and then over where the anesthetized area is, then I advance this Tui needle into the supraspinatus tendon to contact the calcium deposit. Once I have contacted the calcium deposit, then I begin my fenestration, which is basically advancing and withdrawing the needle, and then I angle the needle in multiple directions so I get different parts of the calcium. So this is the traditional way we do it in the in-plane technique. You can, if you prefer, you can also use a out-of-plane technique, and here we'll simulate the out-of-plane technique. So again, the skin is first anesthetized, and then I would use my needle in this out-of-plane technique. In my actual practice, I find it's helpful to use both because some areas of the calcium deposit has better access using the out-of-plane technique. Now, the other approach is once you see the supraspinatus tendon, you can actually rotate the probe 90 degrees so you see a short axis view of this particular tendon, and here's a short axis view of the supraspinatus tendon, and I will freeze it for you here, and using the pointer again, this area here, this hazy area, is the supraspinatus tendon, and here's the cortex of the bone and the superficial deltoid muscle. Now, when we do this technique, after we fenestrate, we will then try to aspirate as much of the calcium as possible. And the way that we normally do this is we have a large syringe which is filled with sterile saline, and then we will basically irrigate and aspirate. So we irrigate as we enter the calcium, and then we try to aspirate as much as possible. So this is a very simple technique. However, I should mention that oftentimes the calcium deposits are quite large, and they're actually larger than the bevel of our Tui needle. So it's not possible to remove all the calcium. If the calcium itself is more of a toothpaste consistency, which is oftentimes the case, then we're better able to aspirate and to lavage the calcium. Nevertheless, when you have residual calcium deposits, the patient still will see improvement in large part because with the calcium broken up into smaller pieces, it's far easier for the body to absorb the calcium. And I've had many patients who have noted remarkable pain relief even though there's some residual calcium. So it appears that much of the benefit comes not necessarily from aspiration itself, but rather from breaking up the calcium deposits to facilitate
its absorption, which of course is part of the natural process. Now, finally, after we have completed our fenestration, we then go and we inject the bursa. So here I'm going to simulate this procedure again, and then we will take our needle attached, and then we will go into the bursa, and then we will inject. And so let me show you this picture here. Using the pointer, I just want to emphasize the bursa is where this white line is, and so we just go into this bursa, and then we inject our mixture of local anesthetic and corticosteroids. I normally use methylprednisolone. Once we finish the procedure, we wipe off the shoulder and we place a band-aid on. So that is the procedure for fenestration, or sometimes called percutaneous needle tenotomy of calcific rotator cuff tendinopathy. Hi, we are now going to proceed with the demonstration on the lateral epicondylis, fenestration or percutaneous needle tenotomy of what's commonly called tennis elbow. So here you'll see Linda is sitting on the gurney and her arm is rested on a male stand. I normally like to place a towel to have her arms rested, and then I have the arm slightly flexed. Now if you look over here, you'll notice a very prominent protuberance, and this of course is the lateral epicondyle. So using this as a reference, now we're able to scan. So I just put my transducer on top of the eminence, and then you'll notice on the ultrasound screen her lateral epicondyle, but also notice the elbow joint. And then you'll also notice the tendons right there. So I'm going to freeze the image for you. It's the lateral epicondyle, and this is the joint itself. And you'll notice some tendinous structures here inserting on the lateral epicondyle. And this actually is our target spot. So when we do the fenestration, we will typically use a small needle. Typically I use a 22 gauge needle, and then you can start fenestrating where the calcifications is found, or where you have the tendinopathy. So it's very similar in principle to the technique that we use for the calcific rotator cuff tendinopathy. So here we go, and I'm going to have Linda just hold her arm like this. And so if you look at the transducer position, and could you please come and show this a little more closely? I wanted to mention that using the implant technique, which is typically described, is technically very, very difficult. When we describe the technique, most people describe it in this approach. However, because Linda has very little subcutaneous tissue, and because of the size of the transducer, it's very, very difficult to do this procedure in the implant technique. So what I have found more helpful is to approach the tendon in an out-of-plane technique. Of course, you can use both techniques and then decide which one is best for you. So for very thin patients, as we have with Linda, I find this is much easier to perform. And so one question people frequently ask me is, how often do you fenestrate? And so there's certainly no golden rule. However, I generally find that when you initially start, there is sort of like a crunchy sensation as you fenestrate back and forth. After about 15, 20, 25, even 30 times, that crunchiness starts to dissipate. And that suggests that much of the calcium, if there's calcium, has already been broken up, or the tendon has become adequately fenestrated. So at the end of the procedure, then you are advised not to inject corticosteroid. And the reason being that as a fenestration technique, we're trying to promote healing. And if you inject corticosteroids, you may actually delay wound healing. So we advise the patients not to take oral steroids or non-steroid anti-inflammatories except for acetaminophen. Then once this is completed, we wipe off the skin, put a band-aid on, and that's the end of the procedure. I want to thank you very much for your attention and your interest in these two very helpful procedures. You will find that they're easy to perform. They're actually very, very safe and quite effective. Additionally, there is a wealth of evidence-based medicine to support their use. If you have any questions, please feel free to contact me through ASRA. I certainly enjoy being presented this to you. And again, I would like to thank Linda for her cooperation.
Please note the ICD-10-CM diagnosis code of M75.3 for calcific tendonitis of the shoulder. Please note the CPT code 20611 for fenestration, arthrocentesis, aspiration, and injection of major joint or bursa, including the shoulder, hip, knee, and subacromial bursa under ultrasound guidance. For a review article on this procedure, please refer to an article Dr. Philip Payne from the Toronto Western Hospital and I wrote in the ASRA newsletter November 2013. I want to thank you for your interest and attention in our webcast video. In particular, I would like to thank ASRA for inviting me to produce this presentation. Thank you very, very much.